Madam Kapoor was my teacher in Agra. So मुझे हमने वहाँ से सीखा, मैडम ने ट्रेनिंग रैगिंग करके सिखाया था मुझे. So it's my privilege to speak in this API forum on the topic especially which is almost covered by Dr. Ansul. The two important trials he's discussed, Pirelli and Figaro trial, which have shown the cardiovascular benefit and the renal benefit. I am supposed to speak on this conference study. Whenever I talk about kidney diseases, I always say there are only 4 or 5 conditions which has got, well, only 4 conditions in which there is renal failure. That is serum rise of serum creatinine, that is AKI, CKD, rapidly progressive glomerulonephritis, and acute glomerulonephritis. Out of these 4 conditions, all 3 conditions are recoverable except CKD. So the importance of here is managing CKD, and diabetes is one of the most common cause of CKD nowadays. When I was studying the diabetes were on the lower side, usual causes of renal failure were chronic glomerulonephritis. Now diabetes and hepatitis top the list for CKD, and CKD, once the patient has got reached into the renal, there are 5 stages of CKD, and there is, once you diagnose the CKD, there is always a relentless progression toward the end-stage renal disease, and once the patient reaches to end-stage renal disease, you can't do anything except patient will require either or lifelong dialysis, maintenance hemodialysis, CAPD, or will have to undergo renal transplantation. So actually reaching the patient to CKD 5 really actually life becomes very hell. So the thing is to check the progression of CKD, and the diabetes is one of the most common cause of CKD. So there are newer drugs are coming. First drug was ACE inhibitors and ARB, statins, and now newer drugs are SGLT2I inhibitors and MR antagonists. The new drugs have come up, and they have really shown reduce the progression of chronic kidney disease. The point to emphasize in this meeting is the early use of this medicine. So that we have in the physician forum we should have awareness to use these medicine as soon as possible. Whereas the patient goes into the CKD, so every diabetic patient should be investigated for, especially for microalbuminuria. That is evidence of one of the evidence of CKD. So every diabetic patient, you should yearly, Dr. Ansul rightly said, yearly should be examined for urinary albumin creatinine ratio. It's a very simple test. It's done on the spot urine sample. Previously the cumbersome test was 24-hour urinary estimation. That was very cumbersome. Your patient has to collect 24-hour urine collection, and sometimes this give rise to false result, misinterpretation, and many more erroneous things. So UCAR, urine albumin UACR is a very important test. So this should be the point. The important point in this meeting is to emphasize that every diabetic patient should be investigated for urine albumin creatinine ratio annually. So now we are the conference trial. The combined use of the rightly Dr. Ansul said, a combined use of frenulone and SGLT2 inhibitor, AMPA and dapagliflozin can lead to substantial albumin reduction and in patient with CKD. And there are data that the albumin is a surrogate marker for the kidney progression and surrogate marker for CV bad outcome, because albuminuria denotes diffuse endothelial dysfunction. So if you reduce the albuminuria or cut down the albuminuria, definitely this is going to benefit, and data have shown it. Figaro trial, they have shown it that this really gives rise to beneficial effect in the conference trial. Although this is conference trial, it is a phase 2 trial. This again showed beneficial effect. There is 31% reduction and with the help of SGLT inhibitors, and -37 reduction. Albumin urine ACR. The percentage reduction in the urine albumin creatinine from the baseline is, with the help of this DAPA or AMPA, 40 to 45%, frenulone they say 55%. If you combine, there is additive effect to the tune of 73%. So the great benefits are achieved when you combine, when you give all the 3 drugs, maximum tolerable dose of ACE inhibitor of ARB. On the top of that, plus add this thing, AMPA or glyphalogen, and on the top of that you add this thing, MR non-steroidal and now MR antagonist, that is phenderone, give rise to additive effect to the tune of 73% reduction in albumin excretion through the urine. So this slide again shows 30% fall in urine albumin creatinine. The urine albumin is in the urine. Further, 27 reduction in the risk of composite kidney outcome in patient with diabetic, especially urine albumin creatinine ratio more than 30. So this also reduces the composite kidney outcome. Composite kidney outcome means the bad outcome. That is doubling of serum creatinine, reaching the patient to the kidney failure, reaching the patient to the end renal disease. So once you reduce the albumin excretion, the composite end point of the kidney also simultaneously they decrease. So there is 30% decrease in albumin excretion and simultaneously 27% reduction of composite kidney outcome. That is doubling of serum creatinine or progression of GFR to and taking to the patient to the end renal disease. So there definitely decreased incidence of end renal disease. The risk of progression to kidney failure, heart failure and death can be dramatically reduced with a combination therapy. You can see here, if you add this thing, RASI means the renin-angiotensin inhibitors, SGLT2 inhibitors and phenderone, you combine the three at the age of 50 years. At the 50 years of age the patient, you can give the benefit of this thing. Heart failure incident patient will survive more 26 years with the RASI only 22 years there is, so the more chances of 6 years more chances of survival if you combine phenderone. All cause death again with the triple combination, the survival is more about 22 years and the kidney failure, the prolonged the life extend to 19.3 years in comparison to 14.4 years and composite kidney outcome 16.7 years. That is to say, if you add the phenderone to the RAS inhibitors and SGLT inhibitors, you gain 4 or 5 years or 6 years more to the life, more to the quality of life. If this drug is added to the at the age of 50 years. So the point to emphasize is there is always a hindrance, there is always a hesitation in accepting the guidelines of whenever the new molecule come. So point to emphasize is early use of this triple combination will give definitely much more benefit to the patient. This is the confidence study data of 800 patients, 75% male, 25% females, mean age group was 66.5, BMI was 29, mean GFR 54, median albumin excretion 579, normal excretion is less than 30 milligram per day. Microalbuminuria is called 30 to 300 milligram, and more than 300 milligram per day is macroalbuminuria. So more than 300 milligram per day excretion means the severest form of renal injury has occurred because of diabetes, and this is chronic kidney disease. And the importance of diagnosis and following diabetic patient with the help of urine albumin excretion is that if you diagnose the patient, if you pick up the patient at the between 30 to 300 milligram with the strict control of sugar, blood pressure, ARBs, SGLT inhibitors and phenderone, you can reverse back it to normoalbuminuria. Once the patient comes out of the 300 milligram per day, this is not reversible. Although the progression can be slowed down, but this cannot be reversible. So here is the importance of following and screening for albumin UACR in a diabetic patient. Simultaneous initiation of phenderone and SGLT2 inhibitor led to reduction of albumin by 30% at day 14. आप देखिए 14 डे पर जैसे क्लासिकल थिंग्स ऑफ इम्पोर्टेंस at the 14 days of combining there is 30% reduction of albumin excretion, and this is the data of ADA recommendation. American Diabetic Association recommends कि if you reduce 30% albumin excretion this give rise to beneficial the thing as far as CKD progression and cardiac things are concerned. So ADA target is 30%, and this is achieved within 14 days. So this is a very important drug, and the combining the phenomenon with the SGLT2 inhibitors, obviously on the top of ARB and ACE inhibitors, target achieved within 14 days. So this appears to be a wonderful drug. And after 30 days, 35% reduction in albumin excretion. Then after 90 days, 49% reduction in albumin excretion, and 52% reduction in albumin excretion after 180 days. So this is a very significant decrease in albumin excretion with the MR antagonist. Now, simultaneous initiation of phenomenon and SGLT2 inhibitors led to early and relative reduction of your albumin excretion. We have already discussed this thing. The 70% of patients simultaneously initiated on phenomenon and SGLT2 achieved the ADA recommended target of more than 30% reduction in albumin excretion. You can see in this slide the combination, and within 6 months 30%, then 40%, and then 50%. 50% albumin excretion can be achieved in 54% patients who were given combination, and more than 40% in 64.2%, and more than 30% and 70% who were given the triple combination. The confidence supplement real world. Now let us discuss the real world. This supplements the real world evidence supporting the combined use of phenomenon and SGLT inhibitors clinical practice. Real world evidence means the things are which are being used in the clinical practice. So clinical practice have also confirmed the confidence trial result. This is beneficial. Simultaneous initiation of phenomenon and SGLT2 inhibitor were associated with reversible reduction in systolic blood pressure, and initial eGFR decline, however, was not associated with serious kidney adverse event. This combination reduced reduced little bit of systolic blood pressure, but this was not very significant. This reduced GFR also, but this was of non-significant, and because of hemodynamic effect, once the phenomenon was stopped, this became normal, came back to the baseline. So this was the hemodynamic effect, nothing to do with the histopathology of the kidney. This is for systolic blood pressure, and this is for eGFR. eGFR was little fell down. eGFR little fell down, and then after once the drug was stopped, it again came back to the normal. So this shows the hemodynamic effect and not the histopathology effect. Numerically lower incidence of treatment emergent hyperkalemia and combination therapy compared with the phenomenon. So you can see the hyperkalemia. I've been using this drug in 4 or 5 patients, and for the last 3 or 4 months I've been using it. There is definitely little incidence of hyperkalemia. Usual patient was having 4.8 and then get this raised to 5.2. But this was managed conservatively and was not of very significant. Similarly, the confidence trial have shown it. With the combination there was 9.3%, and alone phenomenon 11.4%, and empagliflozin 3.8%, and the combination therapy you can see leading to discontinuation of drug only in 1 patient. So this does not of great significance. But you have to watch for hyperkalemia. Once you start phenomenon, you have to watch for serum creatinine and potassium level. You have to measure it every 1 to 2 weeks initially, then every 2 weeks, then every month, then every 3 months. So you have to follow the hyperkalemia point of view. See, once more and more experience comes, you will become more confident regarding this drug, side effect. Otherwise, hyperkalemia that is of very little significance. Usually, this drug is very well tolerated. This is my data, 5 or 6 patients only. Overall adverse event profile for the combination was similar to that of either agent alone. You can see serum potassium threshold 5.5, 5.5, and more than 6.5 was very less. Serum potassium elevation more than 6 were uncommon in patients simultaneously initiated on phenomenon and SGLT inhibitors. This is a little bit of protective effect because SGLT inhibitor causes diuresis. So little bit of diuresis must have given protection to the elevation of hyperkalemia potassium level. So you can see the previous slide. This is combination has little less incidence and phenomenon alone has a little higher incidence of it. This the combination has given some sort of protection. The AKI incidence are negligible, almost negligible. The symptomatic hypotension almost negligible. Simultaneous initiation of phenomenon and SGLT2I inhibitor in patient with CKD and type 2 diabetes led to early reduction in albumin excretion, which was significantly greater than with either agent alone. That is up to the tune of 52%. 70% of patients achieving the ADA recommended albumin excretion more than 30% within 6 months. So overall adverse event profile for the combination was similar to that of either agent alone. Now implications of confidence, key conclusions. The CKD associated with type 2 diabetes remains a global issue and patients live with a residual risk of kidney disease progression despite advances in treatment options. Confidence provides support for a simultaneous approach to initiating phenomenon and SGLT2I, complementing existing real-world evidence for phenomenon and SGLT2I combination therapy. Finding from confidence may also help alleviate common concern around simultaneous initiation of combination therapy and encourage earlier action to improve patient outcome. So phenomenon is an essential treatment pillar in CKD with type 2 diabetes. Its early combination with an SGLT2I should be considered an optimal approach to rapidly reducing albumin excretion, and that is associated with the increased CV risk. The point to emphasize in this meeting is start this therapy as soon as possible. And in a diabetes, screen the diabetic patient for albumin excretion. If you find CKD means patient is passing albumin, you combine these 3 drugs, ACE inhibitors to the maximum tolerable dose of ACE inhibitors or ARB plus empagliflozin or dapagliflozin. Obviously, be careful about the side effects. Empa and dafa, they are prone to cause UTI, and especially those U-detect infection patients, they should be avoided because I have seen some patients who are diabetic patients always prone to develop UTI, and that is complicated UTI. Patient was was on EMPA, patient had UTI and he developed pyelonephritis. So be careful about symptomatology. Look for symptomatology of UTI, and as far as a simple test, you will look for urine pus cells. If you pus cell present, stop this and do the culture and investigate pyuria. Now, guideline recommendation. This is a phase 2 trial. Usually, whenever the drug is recommended, usually recommended after phase 3 trial. This is phase 2 trial, but other trials have shown, Federo and Fidelio trial, they have shown the use of this thing. And many guidelines like ADA guidelines, KDICO guidelines, ASC guidelines, they have recommended this drug. And look at the level of evidence, class 1A evidence. Evidence is a very strong evidence to support. So let us, I think let us start. We'll discuss on the physician forum. Let us start this, let us make use of this molecule for the benefit of the patient, and let us have our own experience and our own registry for the Bundelkhand API. Phenomenon is approved in India with the same indication as the US FDA. So phenomenon is indicated in adult patient with CKD associated with type 2 diabetes to reduce the risk of sustained eGFR decline, to decrease the incidence of end-stage kidney disease, to decrease the incidence of cardiovascular death, to decrease the incidence of non-fatal MI and hospitalization for heart failure. This is a very, very important scenario, and okay, this one. So in Fidelio and Figaro, Potassium management used to be simple. You follow the potassium hyperkalemia management. You just general practice with the help of practice, you can manage the hyperkalemia. This is not a big concern for this drug. So thank you very much. And if there are questions,
Sir, last question.